right, good morning, everyone. Thanks for continuing on your journey through our conference today. I am excited to introduce everyone for this panel because they're my people. My name is Molly Berry. I'm a medical oncologist at the University of Vermont and executive director of the Women's Health and Cancer Conference. It's my pleasure today to introduce today's Moving in Your Environment, the role of exercise and nutrition in cancer care panel facilitator, Dr. Chris Anker. Dr. Anker is a professor in radiation oncology. He serves on the UVM Cancer Center senior leadership team through his role of co-leader of the Cancer Host and Environment Program, along with Dr. Jason Stump. He's helped develop and bring numerous clinical trials to UVM, and on a personal note, he is an amazing colleague and someone who I love working with. So I am happy to introduce Dr. Anker.
All right. Honored to be here as the moderator today for this very interesting and important session. So as the leader of this Cancer Host and Environment Program, I get to work with some amazing people like my colleagues here, including Dr. Hibba Rehman. She's an assistant professor in medical oncology and director of the sarcoma transdisciplinary team. She is a member of the Cancer Center leadership as chair of the protocol review and monitoring team. This group is really essential here at UVM. I was a member of it previously, and so she's the leader of this group that goes over the scientific integrity and process of every clinical trial that's coming through our institution. And her work focuses on exercise and how it may have the potential to improve cancer control. And Dr. Toth is professor of medicine and vice chair for research, and he's been funded very well for many years through the NCI to help study exercise and cancer patients. And it's just really tremendous work from him as well. Now, Dr. Conor O'Neill, I expect he'll be coming hopefully shortly to discuss nutrition in cancer care, another, of course, interesting topic to everyone. He's an assistant professor in surgical oncology and director of the upper gastrointestinal and hepatobiliary teams at UVM. He notes that poor fitness and nutrition are quite common in patients that he sees as they struggle with their cancer and otherwise, and he's doing grant-supported work to help people and support them so that they can do better. It's been certainly a privilege getting to manage this cancer program. So what I get to do is I work with a number of fundamental scientists and clinicians who are all trying to figure out how the cancer cells, the tumors interact with the host to either cause more problems for patients, and there's some things that interact with the human body and they promote cancer, but then there are of course things that we can do to help impede cancer. So I don't want to talk too much because they have a lot of interesting things to say about their research in these matters, and I expect that exercise and nutrition are at least great interest to everyone's in the room. They're probably going to have a number of questions, so we definitely want to give you time for all of that. So without further delay, I'll have Dr. Rehman come up to the mic here. Thank you.
Apologies, I forgot one part of my introduction, which was about the question and answer. When question and answer opens, Zoom attendees, you can chat your questions and a volunteer will read them out loud. For in-person attendees, a reminder to please wait for a microphone to ask your question. Otherwise, our virtual attendees will not be able to hear you. And with that, I will turn it back over to Dr. Rehman.
Thank you so much, Dr. Anker, for that kind introduction. So, exercise for cancer patients and survivor. I'm so honored and it's a pleasure to be here with all of you to talk about a topic that is really near and dear to my heart because it makes a big impact in care of our patients. The goals for our discussion today are, number one, why exercise is so important for care of our cancer patients. And secondly, what are some of the barriers that our patients face and how we can mitigate those barriers or problems? And lastly, what are some of the future directions that we can take to incorporate exercise in care of cancer patients as well as survivors? Human mind is interesting. We don't really commit to doing something unless we really understand why we want to do something or don't do something. And it's crucial that we really get to the bottom of why it is necessary for our patients to exercise and stay physically active. There have been multiple studies, and this one specifically was a multi-institutional study looking at symptom control for cancer patients. And our cancer patients are dealing with symptoms not only from their cancer, but also from the treatments that we have to offer. And the study clearly showed that there was improvement in the quality of life of patients, as well as their ability to cope with stress and ability to make decisions, which is so important for a patient's autonomy. And as a provider caring for cancer patients, it is really important to me that the time that they are gaining from any cancer-related therapy is a quality time and not making them miserable through the time that they are gaining from all the types of treatments. Another study looking specifically at early-stage breast cancer patients looked at the toxicity from systemic therapies. Grade 3 and 4 toxicities are side effects that we really care about because they are intense. They can put people at risk of complications, hospitalization, and treatment delays. So it's important as oncologists for us to look at factors that can cause those grade 3 and 4 side effects. And this study specifically looked at about 151 patients who were getting treatment for breast cancer. And all the side effects were noted to be much more in patients who were dealing with sarcopenia. Now, sarcopenia is a medical term used for lack of muscle mass and strength. Previously, it used to be thought to be related to age-related decrease in muscle mass and strength, but we know that younger cancer patients also deal with sarcopenia. And one of the meta-analyses actually showed that anywhere between 19 to 76% of cancer patients are dealing with sarcopenia. And why is that relevant? If we look at the toxicities, the top bar shows all kinds of grade 3 and 4 toxicities, and we can see that patients who have a healthy muscle mass and function tend to have much less, almost 50% reduction in the toxicities compared to patients who do not have that. Hematological side effects are the side effects that pertain to blood counts, like white cells that fight infection, red cells that carry oxygen in our body and provide us energy through the oxygen utilization, and platelets that help in making a clot. All those cells can get affected by chemotherapy, but they get affected more if someone has sarcopenia. Gastrointestinal side effects like nausea, vomiting, diarrhea, constipation, abdominal pain, those side effects were also noted to be much more in patients who had lack of muscle mass and function or sarcopenia. And same was true for neuropathy. Neuropathy is one of the problems with some of our chemotherapies, and you would think that nerve and muscle are two separate things, but actually sarcopenia impacts the toxicity from chemotherapy on the nerves as well. And the rate of hospitalization was also more in patients who had sarcopenia. And that led to more dose delays of next chemotherapy, dose reduction, and in some cases, altogether, the chemotherapy had to be stopped. Now, sarcopenia is not something that is permanent. It can be made better by different regimens of exercise and appropriate nutrition. This study specifically looked at patients in above age of 65, so it was not a cancer-specific study, but it did show that patients who underwent resistance training, either alone or in combination of Yi Jin Jing, which is a special exercise training that is Chinese in origin, showed significant improvement in patients' muscle mass and function. And in comparison to the control group, which is mentioned in the middle of each of these graphs, if we look at before and after results for those measures, all of those patients who were either in the resistance training or the combination arm, they did better compared to control arm. Now, exercise doesn't only have impact on muscles, it also has cognitive benefits. A lot of our chemo patients or our cancer patients who are undergoing chemotherapy, they report a phenomena called chemo brain, which basically reflects cognitive dysfunction, memory lapses, and other other challenges that these patients are experiencing during their treatment. And exercise has shown to reduce the incidence of chemo brain. This study was specifically done on breast cancer patients. And if we look at the orange bar, which shows the patients who were able to maintain the recommended level of physical activity, which is moderate to strenuous activity for 30 minutes at least 5 times a week, or 150 minutes of activity per week, those were the patients who did really well despite chemotherapy. So the time 2 is where they were assessed after getting chemotherapy, and then a few months later they were reassessed without having any chemotherapy, and they continued to do well on all the cognitive testing and other measures that were used to assess chemo brain. Exercise has recently also been associated with a better gut health. And gut microbiome is an evolving area of research. And we know now that exercise, especially higher intensity and higher duration of exercise, can be associated with positive change in the type of bacteria that are present in our gut. And gut bacteria are constantly interacting with our immune system that is lining the gut itself. And it can actually impact the outcome of immunotherapy and other cancer-related treatments. One important finding from the study was that adherence to exercise was really the key. So the benefits go down if the patient stops doing the exercise. So it is not something that you do one time and you gain the benefit forever. It is something that you would need to do on an ongoing basis to reap the benefits. And another good news that this benefit was noted not only in general population, but also in cancer patients. Now, some people say that maybe it is because of a transfer effect, which is a phenomena where if you're doing really well in one domain of your life, or you're learning a new skill in one domain of your life, that effect can transfer in other domains of life as well. So some people say that maybe people who were exercising, they started eating healthy because of the transfer effect, and that led to the change in gut microbiome. But even if it is that, it is a win-win situation, because if you're eating healthy, that is good for your body as well. Exercise also has positive thinking and improved psychological health, and that can also improve several domains of our life. And I do wonder that eventually maybe we will be able to incorporate exercise to improve smoking cessation efforts, because one positive behavioral change might be able to be transferred to another domain of a patient's life. As an oncologist, cancer-related outcomes are very important to me. And just like patient-reported outcomes, cancer-related outcomes are also crucial when we assess the response to treatment. One of the Japanese studies specifically looking at patients with non-small cell lung cancer who have advanced stage disease and were treated with immunotherapy, they assessed the response rate to immunotherapy as well as the progression-free survival and overall survival in those patients. And clearly, there was improvement in patients who did not have sarcopenia or lack of muscle mass and function over the course of their treatment in comparison to patients who lost their muscle mass and function. If we look at these graphs, the first one is just showing a comparison of performance status of patients, which is something that we assess every time we are thinking about starting someone on chemotherapy. We assess how active they are they up and about, are they able to do their day-to-day activities, and that translates into survival as well. And same was true for sarcopenia, as we can see in the second graph here, that people who had sarcopenia did worse compared to people who did not. But a very interesting finding was that even when they corrected for the performance status, people with same exact performance status did much worse if they had sarcopenia in comparison to if they didn't. So sarcopenia itself can dictate somebody's response rate as well as survival from a cancer diagnosis. So we know now that it is really important to incorporate exercise and really important to maintain muscle mass and function in our patients, but that is not easy. Our cancer patients are dealing with a lot of challenges, and there are several barriers to gaining access to exercise classes or to increase in their physical activity in general. Cancer itself and the cancer treatment, they cause a lot of fatigue, and our patients deal with issues related to lack of energy, lethargy. Sometimes right after their chemotherapy, they just don't have the energy to even get up and do things. So how we can make it more feasible for our patients to do those activities and exercises. Our patients are also dealing with pain issues, especially if someone has bone metastasis. Adequately treating their pain is crucial if we are to increase their physical activity level. Nausea and other GI problems also impact somebody's ability to move about. So adequately treating and mitigating those side effects is also really important. And then there is lack of motivation and inadequately managed depression and anxiety. I feel that depression and anxiety in general population is also inadequately diagnosed and managed. And when you throw cancer on top of that, it becomes even more challenging. And then there are limited access to the facilities. Sometimes there are financial constraints, and sometimes those cognitive changes or chemobrain can lead to lack of activity as well. And then sometimes our patients are reasonably worried about, understandably worried about the risk of catching an infection while they are in an environment where other people might be sick. And then lack of social support or isolation can also lead to these problems. And then last but not least, lack of education of providers, which I feel I was also not thinking about exercise in so much depth up until a few years ago when we started working on a research project with Dr. Toth and Dr. Kim Dittis, who kindly agreed to mentor me. And we opened a clinical trial with the help of Northern New England Clinical Oncology Society to understand, are there ways that we can incorporate exercise in our lung cancer patients' treatment? So we utilized a program that is offered through Steps to Wellness, and that is a structured exercise program over a 12 weeks time frame that our patients will have access to. It is free of cost and available both in person as well as on Zoom. And this study is specifically looking at feasibility of such an approach and also how it impacts the outcome of our lung cancer patients. This program is currently running, and this is just a dynamometer through which we assess the grip strength and also equipment to measure their 6-minute walk distance. That would help us understand how some of the objective measures are changing when our patients are doing the exercise. We are currently enrolling to this study, and we're very hopeful that we will see a positive change in the outcome of those patients. We are also assessing some objective measures of skeletal muscle on the scans that are done routinely as care for lung cancer patients. And some of the future directions that we are thinking about are expansion and more utilization of Steps to Wellness program so that more patients can benefit from this free exercise program. And then integration of exercise through multiple referrals. So not only from oncology colleagues, radiation oncology, surgical oncology, but also through nutrition and through our psychologists, people who are counseling our patients. I think it's really important that we all think about exercise as medicine. And then taking this knowledge to prevention eventually is my goal. I'm very thankful for my mentors, Dr. Toth and Dr. Kim Dittis. as well as NECOS and UVM Cancer Center, and above all, our patients and their families. Thank you so much.
Dr. Toth, go on up, and thank you, Dr. Rehman. Excellent talk. Good reminder, too, that there are many clinical trials out there. You know, it's good to ask your provider, what might be available to me? And you might get an answer that involves an intervention that isn't even a medicine. You know, it's something that you really want to do anyways that could really benefit your cancer outcomes. All right, Dr. Toth.
All right, thank you, Chris, and thank you to the organizers for the invitation to present my research. I'm going to take us in a little bit of a different direction. So what Hibba was talking about was more of a standard exercise that we all kind of know. You go to a training place and you do some kind of exercise. What I'm going to talk about is a little bit more non-traditional exercise, and I think it's, and that's what my work focuses. I'm a skeletal muscle biologist by training. I'm not a clinician. And what I focus on is trying to get exercise to patients at times that they otherwise couldn't do this more classical type of exercise. And in my work, what I'm interested in...
Can you speak closer to the microphone?
Oh, I'm sorry. So in my work, what I'm interested in is trying to improve in patients their physical function. And what we're talking about here is your ability to do everyday activities of daily life. And here you can see a graph of the change in physical function in a variety of different patient populations when they get cancer. And what you can see is there's a big range here. What I'll be talking about today is breast cancer. And even though it's not as extreme as some of the more disabling types of cancer, if you compare this to the line showing the line that goes across there, that's normal patients who don't get cancer over the same period. You can see that breast cancer patients experience about twice as much drop in physical function. So it's much worse than aging. And this is where we get this sort of idea in the field that cancer and its treatment actually accelerates normal age-related changes. In particular in physical function, I just wanted to talk about how we look at that on an aging context. So this graph shows how our physical function changes with age. And as we all kind of know, as we get older, things sort of decline. So you can see the normal decline here in physical function with age shown as a simple linear decline. But sometimes, we get sick or something happens to us and we have some kind of event, we're hospitalized, we have to be treated. And what happens is you get this really rapid decline that occurs in your physical function. Oftentimes you'll get a little bit of recovery, it's not really shown on here, but then it just sort of keeps going down at that normal age-related change. And what's unique about cancer and its treatment is it seems to have that same sort of acute effect to cause, that acute disabling effect. But it seems to then progress over time at a more accelerated rate. So people lose their physical function much quicker, cancer survivors do, compared to somebody who didn't have cancer. And what we really want to understand is, why is that? What happens at this time when you have cancer and you get treated for it that accelerates this? And can exercise help protect against that? Because those patients, if you look at them out through the years, and the research holds this up, is that they will go to a level of disability, or their physical function will decline to a point where they'll be physically disabled much faster than somebody who doesn't have cancer or experience it and its treatment. So I'm a skeletal muscle biologist by training, so I'm not going to get too deep into this, but just a little bit to just tell you about some of the research we're doing. So when we're talking about physical function, we're talking about movement. When we're talking about movement, it's your muscles working the way they're supposed to. And one of the reasons why they don't work as well as they should is because they atrophy or they waste away, okay? And this is pretty pronounced. So this study here shows in breast cancer patients over a 16-week time period receiving chemotherapy, what happens to their muscle. So they took a biopsy from their muscle, they took it to a lab, and they measured all the size of the muscle fibers in that biopsy. And what you can see here is that across all muscle fibers, there's two different types. There's these type 1, which are kind of like a marathon runner would have. They're highly oxidative, slow twitch muscle fibers. And there's these type 2, which are like, if you watch the Olympics, the sprinters in track and field, they have a lot of those. And it doesn't matter what kind you have, it is tremendously impactful. It has a tremendous amount of cancer in its treatment, causes a tremendous amount of muscle atrophy. If you put this into context, this is about 30 or 40 years of aging that occurs over about a 16-week time period. the degree of atrophy that's happening here. So pretty pronounced stuff that's happening to these patients. So getting back to that original question, it seems that cancer and its treatment, that time period is incredibly impactful for affecting your muscles. And can we get exercise in at that time to intervene and prevent this sort of more rapid decline that occurs afterwards? So that study that I just showed you actually was part of an exercise study. So they did both aerobic, so this is the classical thing you do, you go to a facility, you do exercise, and they did either aerobic training or resistance training. Both of them had this high intensity interval training component, so pretty extensive type of exercise. And what you'll see is the aerobic training was very effective at improving those slow twitch type 1 fibers, which makes sense because that's the kind you use when you do aerobic exercise. But the resistance exercise was more effective at improving or preventing the loss of muscle in both the slow and the fast twitch muscle fibers. In fact, it actually caused them to grow a little bit. They had a little bit of hypertrophy that occurred there, which is a good thing. So when we think about what type of exercise we might be wanting to get to patients, we're thinking the resistance exercise might be a little bit more effective at counteracting the effects of cancer and its treatment. And this is the important thing, I work as a muscle biologist, but I actually work all in patient populations. And I've had friends and family members who have experienced cancer. And patients with cancer generally, they have low self-efficacy for exercise, and this has been borne out across a number of studies. And when you ask them if they want to do exercise and what kind of exercise they would like to do, they want it mostly to be home-based, and they want it to be low intensity. So all of these studies about exercise are very important, but oftentimes they sort of forget that patients may not want or be able to do that, particularly during treatment when they have very limited capacity. Sometimes there's days when it's very hard to just get out of bed. So what we wanted to do was to see if we could test an intervention to maybe address this issue, and in particular in breast cancer patients. So this is a proof of principle study. It's a very small scale demonstration study where we studied women with breast cancer to look at 8 weeks of an at-home exercise regimen with what's called neuromuscular electrical stimulation, which I'll explain to you in a second. And we looked at how it affected the muscles directly. So we took muscle biopsies in these patients before and after this intervention. And so what is neuromuscular electrical stimulation? It's basically what it sounds like. You use a small handheld unit and some electrodes over your muscles, and the machine basically makes your muscles contract. It's the best exercise ever. You could sit and watch TV and do nothing, and the machine will actually exercise your muscles for you. It's commonly used in orthopedic injury and surgical patients when they can't move, their muscles around a joint or an injured or surgical joint or limb. It's been shown to tremendously protect muscle, but it's also been used in some patient populations, more specifically in like critical care situation where patients are bedridden for long periods of time. And it has a lot of benefits. It hasn't been used in cancer patients very much. So we published this work actually right before the pandemic, fortunately, because it was very hard to do these types of studies during that, on breast cancer patients receiving chemotherapy. And I wanted to focus really on, as I said, we use a resistance type exercise approach with this device. And the key thing with resistance exercise, it's supposed to make your muscles grow, right? And what we found with this study, quite interestingly, it's, again, proof of principle. All we want to do with this study is show that this device can work like regular exercise in these patients. And what we found was there was an increase in muscle fiber size in the patients that received the neuromuscular electrical stim. So check that box, works just like resistance exercise like it's supposed to. And then this is a little bit esoteric, but I'll try to walk you through it. This is a slide showing the results of what kind of fibers are in the muscle. So remember I said there's a slow twitch and a fast twitch? Well, in our control group, what you can see is that they actually had a switch from one type of fast twitch to one that contains both two different types of fast twitch. And then in the group that received the neuromuscular electrical stim, it was a switch, but in the opposite direction. So you guys don't understand what that means, except for the fact that the switch that we saw in the control emulates what you see if you just take someone and put them on bed rest. It emulates disuse, which is detrimental adaptations in your muscle, okay? And what we saw in the neuromuscular electrical stim, again, checking that box, looks exactly like resistance exercise. We get that same shift in fiber types in a muscle that occurs when we do resistance exercise. So in both cases, our neuromuscular electrical stimulation exercise appears to act very much similar to just standard resistance exercise. So that's what's important to the patients is, can I do more? Can I go out and do more of my functional things that I want to do day to day? We did measure those things like 6-minute walk, and we measured muscle strength, and those things didn't really change over time. But it was a short study. It wasn't powered to do that, and not to mention the fact that we tested these patients while they were still receiving chemo. A lot of patients reported when we were testing them, doing the walking test or the strength test, that, I don't really feel like I could do this well today. It's really hard. So these kind of tests are really difficult to do in patients when they're receiving treatment. And that's why we took the muscle biopsies from these patients, to really demonstrate that this works. So I just wanted to conclude by saying exercise is good. We kind of knew that, right? But it does help preserve your muscles, and it does help make you more functional, and it definitely works in cancer patients during treatment. Incredibly hard to do. And at least from what we have from our preliminary data, is a home-based neuromuscular electrical stimulation program might be effective at inducing those cellular responses to exercise that we know of and think should occur. So it seems to be working like it's supposed to. However, it didn't really counteract the muscle weakness or improve physical function in these patients, with the caveat that these patients were tested during chemotherapy, which is a very hard time for them to do those kind of tests. And I just want to say, I stand up here today because I have a lot of great colleagues like Dr. Rehman that helped me do this research, and I would be remiss in not thanking them for doing this. That's it. Thank you very much.
All right, thank you, Dr. Toth. Clearly we want our patients not just, surviving, but thriving as much as possible. And, so I've learned so much from this team here. I really want to emphasize exercise and also nutrition when I speak to all my new patients. And so thank you, Dr. O'Neill, for not just covering for your colleague in the operating room today, but getting it over here, despite the unexpected challenges.
Yes, the school closure in Williston led to a lot of changes, so I'm sorry for me running in and looking disheveled, and also sorry that I have to follow a muscular biologist. Good God. I am not a nutritionist. I'm not a Ph.D. in nutrition. I'm a surgeon, and I mostly take care of patients with liver and pancreas cancers, as well as esophageal and gastric cancers. So nutrition has become very important for me in how I counsel patients. That's all I'm here to talk about. I think the NCI, the National Cancer Institute, which is a branch of the National Institutes of Health, has had long, ongoing investigations into the role of nutrition in specific nutritional components. We know acrylamides, charred meat, artificial sweeteners. They may all have a role, though no firm links have been established. We do have some animal studies that can suggest roles in either the prevention or the propagation of malignancy. Certainly, high salt diet for those who treat esophageal cancers, or smoked fish and meat, heavy alcohol use, all can play a role in direct toxicity to the stomach and pancreas. And certainly, vitamin D deficiency has shown a role not only in the initiation, but also the propagation of breast cancer. I think there are two studies that are worthwhile to visit here. Researchers at the University of Texas Medical Branch, my home, had created an international database that was published in the Journal of Clinical Oncology earlier this year. In females who are over the age of 40 without any history of breast cancer, they were all postmenopausal. One group had a serum vitamin D level that was less than 20 milligrams per deciliter, a low level, and the other was greater than 30. Otherwise, these groups were completely matched. And women with low vitamin D had a 45% greater chance of developing breast cancer, risk ratio of 1.45 for those who are more statistically inclined. So I think that changes really how we approach cancer care. I think since ancient times, surgery has been the main pillar of cancer treatment. If there was a tumor, resection was the only opportunity for durable cure until the end of the 19th century, when radiation became available. And together, radiation and surgery were really the only options until cytotoxic therapy around World War II. We're now tripping over ourselves with molecular and targeted therapies and immunotherapy, but I really think that we need to have a sixth pillar that's catching some steam, but is focused on lifestyle medicine. I have to follow, Hibba and Michael and their great talks, but I think the main components here is in the treatment or in the prevention, but especially here talking about the treatment of cancer, we need to focus on the role of nutrition, exercise, stress management, substance abuse, and our own mental health. We know that nutrition plays a role in our ability to fight cancer. 80% of patients with breast cancer, like we talked about, breast cancer can be at least a little less morbid than some of the GI tract malignancies where you can't eat or swallow or you have fat malabsorption. Still, 80% of patients with breast cancer will have a nutritional impact while on systemic therapy. So there's an interesting study that came out of Yale at the end of last year in combination with Dana-Farber as well as MD Anderson. And they had two groups. One was just a usual care patient with early stage breast cancer. So they had systemic therapy followed by surgery, followed by hormonal therapy, versus a group that had nutrition counseling prior to surgery. And their primary outcomes were looking at the rates of therapy completion. Could they complete all their cycles on time without dose delay or dose reduction? And they wanted to see what the tumor response was to treatment. The study was pretty simple. It just said, have a predominantly plant-based diet, try to have mostly fruits and vegetables, greater than 5 servings a day, high fiber, avoid sugar and red meat, and try to reduce your alcohol intake. Those same services were available to the standard of care, but they were not required to enlist and did not have nutrition counseling as part of their care unless they requested it. These groups were otherwise, again, fairly well matched. And in this very busy but important slide, they showed that during the course of their systemic therapy, diets worsened, just like we showed with exercise, without counseling, and their inactivity increased. And perhaps most importantly, the pathologic complete response rates improved. The leaner group, this group that got nutrition counseling, they had fewer adverse events during the course of their therapies. They had lower rates of mouth sores or other complications that led to dose delays or reduction. But they're also 25% more likely to have a complete response. So 53 versus 28 response in early stage breast cancer, hormone receptor positive. They also looked at relative dose intensity. This is kind of a tricky number, but if you look at what the prescribed best therapy is, you're supposed to get full Ferrinox, which is a god-awful concoction of drugs that's given every 2 weeks. We're able to stay on target every 2 weeks without any dose delays or reductions. In breast cancer specifically, we know that a low RDI, or relative dose intensity, occurs in about 26%. And in dose-dense regimens, it's about 32% of patients. So it's common, especially in my cancers. And we know that that's important. New England Journal of Medicine showed, now a couple decades ago, that patients who cannot receive 85% of their prescribed therapy have an absolute worse survival by about a third long term. In HPV, so liver, pancreas malignancies, our best data suggests that it should be around 80%. Dose delays are much more common. So we began a nutritional therapy program here. We know that it's important here in our rural state and also our rural catchment. 60% of patients present with malnutrition, 20% with severe malnutrition. And almost a quarter of patients have some sort of unplanned admission related to their systemic therapy, or they have significant treatment delays. So we assessed our complications pre and post the nutritional intervention. So this was sponsored by the Victoria Buffum Foundation here at the University of Vermont, and now we have routine dietics care for all patients. And we found several changes. Number one, by about 20-fold within the course of a year, we improved the likelihood that a patient diagnosed with pancreatic cancer was able to make it to surgery. And these were in borderline resectable and even resectable patients. They weren't fit and they didn't have the nutritional status to get there. A 20-fold increase in 1 year. Yeah, I'm trying. It's not my jam. I can't yell. I'll try. But also esophageal surgery. So you remove the esophagus and you have to make a connection. And that connection is in the chest. And leaks happen about 20% of the time. And as you can imagine, an anastomotic leak in the chest is a dreaded complication, 20% of the time. In that year, we found that the single most protective factor for avoidance of a leak was having a dietitian follow you through their preoperative care. It actually led to a 0% leak rate, having a nutritional interventionist. So, yeah, I know, time's up. So, what we found, about 48% of patients were moderate to severe, so worse than national averages. 48% moderate to severe malnutrition. About 20% required feeding tubes to get through their therapy. But we were able to curb their mean weight loss to only 2% while having a nutritionist. Now, across the network, we were able to achieve a relative dose intensity, so the ability to complete chemotherapy up to 84%, simply with a nutritional intervention. So I'm very thankful to that program. I'm done. Thank you.
All right, time for a few questions.
So it seems pretty dramatic, the muscle sarcopenia effect. And what do you think is the actual mechanism of how that's happening, that it helps so much with such a diverse range of side effects?
Yeah, so it's probably a combination of things. So patients become incredibly physically inactive during cancer treatment. And then the cancer treatments themselves probably have detrimental effects on the muscle, and we've studied that and shown that pretty clearly.
But I mean, is it because there's so much blood flow in muscles? I'm just trying to understand how it actually works.
Oh, well, muscles, if you don't use them, you lose them. That's the kind of adage happens. And if you don't use them and you're sick, you lose them very quickly. Why that is, not 100% sure, but muscle serves as a reservoir of substrates that your body uses to make things like sugar, glucose, to maintain your blood sugar. So there's a lot of different reasons why muscle wastes like that in different conditions, and cancer seems to be one of the more potent conditions that can do that.
Thank you, Dr. Toth. And I would just add that when people are exercising or they are more physically active, they are reducing the risk of several other complications as well, like risk of blood clots that are related to physical inactivity. When muscles are active and you are building on muscles, your glucose metabolism in the body is also different, and how much insulin gets secreted, how much stress hormones will get secreted, that balance is also maintained because muscles are utilizing a lot of the glucose in our body. And we know that there is at least some correlation of the glucose level in the body and how it is utilized by cancer and other cells. Not all of those mechanisms are fully understood, but muscles are basically an organ system that is interacting at multiple levels in our body with different hormones, cytokines, other chemicals that maintain that balance in our body. Thank you.
I have a question from the online group. This one says, my oncologist told me that radiation therapy will continue to shrink tissue over time. Is it recommended to continue to stretch and massage those tissues to break up the tightness? And do you have any suggestions going forward to prevent that?
Well, I could start to answer that as a radiation oncologist, but absolutely, we should all be ideally stretching every single day as it is. But then when it comes to radiation therapy, which causes stiffening of the tissues and scarring, it's even more important. And it just the frequency and intensity of the stretching maybe should be a little bit greater as you're going through the acute recovery phase. I do encourage patients to ask their providers about seeing a physical therapist for a more directed program, because you're going to get a lot better, more accurate information from someone who's a professional in that. But for example, physical therapists that I refer patients to a lot are pelvic physical therapists. That's actually like a fellowship. It's more a training than just on top of typical physical therapist, and they really help with squatting down, getting up, and in addition to anorectal function and even sexual function too. So, great question. Thank you.
I'm just curious if you know if anybody's studying blood flow restriction and activity with blood flow restriction as far as during cancer and cancer treatment.
So I would say there are certain situations where we try to reduce the blood flow. Like there are some studies looking at reducing the risk of peripheral neuropathy by cooling down the extremities. People wear cold caps to reduce the risk of hair loss from chemotherapy, because when you reduce the blood flow that contains the chemotherapy, you reduce the risk of damage to a specific organ. The same applies to certain other chemotherapies when we ask patients to take ice chips while they're getting the chemotherapy, because it reduces the risk of mucositis or inflammation in the lining of the mouth. So those are some of the examples where we know that there isn't a detrimental impact in terms of cancer outcome, but we can prevent or reduce the risk of certain side effects.
I'll just add to that. One of the things as an exercise physiologist that doesn't see patients, I'm often told by clinicians, if I would come to them and ask them to do that in a cancer population, they probably say no. And I don't know of any studies that are doing that for the simple reason that their cancer patients tend to be prone to blood clots. And so if you restrict blood flow like that, you're at a higher risk for that. And you may have small blood clots that you can sort of dislodge by causing large-scale flow after you restrict blood flow like that. So I don't know of any going on like that. I don't know if anybody's ever proposed it for that reason. So it might be a little bit more risky in patients with cancer and getting treatment. So it's not something that I know that anybody's tried yet.
We have two final questions from our virtual audience, and then I'm going to have to call it for the rest of the session, but I'm excited to see that there are so many people interested in this topic.
Yes, are there any studies on how exercise helps patients with long-term chemo brain?
So one of the studies that I included in my talk was actually published in Journal of Clinical Oncology, and they did follow patients several months after their completion of treatment. And there was a significant difference in patients who continued to do exercise. They tend to have better memory, better cognitive function, and better analytical abilities.
How do you suggest approaching a patient who is resistant to nutritional interventions but is fragile leading up to surgery and treatment?
That's a great question. At the end of the day, it's an assessment about whether or not they would be safe for surgery. So we have a lot of leeway to cajole patients to do the right thing. A patient who can't participate is not going to be able to undergo a curative resection. Now, at the end of the day, also, if a patient is fit enough, you do your best as you can to meet a patient at their goals. We've had several patients recently who are just too overwhelmed to participate in Steps to Wellness. The idea of that was exhausting. Nutrition, they seem a little less resistant. I think somebody helping them, especially in our scenario, we're not counseling South Beach diets. These are high protein, high calorie to switch from a catabolic state to more of an anabolic system during their preoperative care. And they usually find that somewhat comforting.
All right, thank you everyone for your attention today. Really appreciate it.